Okay, good evening, everybody. Let's start with this session, 17th session from 51st Comprehensive Course on Echocardiography. All of you must have taken the exams by now, and we are going to discuss about this particular exam today. Well, I'm Dr. Rakesh Gupta from Jorap Institute of Echocardiography, Ultrasound and Vascular Doctor from Delhi. We are into this teaching work since April 2000. This is our auditorium where we conduct normally our hands-on training programs. The legends behind this training program is none other than Dr. Parashar, Dr. H.K. Chopra, Dr. Sami Srivastava, and Dr. Nanda is our international president, and we have Dr. Hansa Gupta, who is also a course director. Two people who will be talking again and again. One who looks after local hospitality when you're in Delhi. Second is Mrs. Reena Dua, when you'll be talking to her off and on during this training programs. We have multiple accreditations from Indian Academy of Echo, International Society of Cardiovascular Ultrasound, Alabama, USA. We take two permissions from Delhi Medical Council, and all hands-on training programs are in consensus with Chief District Medical Officer of Northwest District or the state appropriate authority. We are conducting a big one-year training program in a fellowship of echocardiography from Parul University. And last year, we were instrumental in sending students to UK, technicians to UK via BAPIO. Well, we can boast of saying we are the only institutes which provides hands-on training since April 2000. And till date, we have provided more than 5,000 delegates training. Almost 25 years of glorious years. In April 25, we completed without any single break. And we are celebrating this on 17th August 2025 in Delhi. All of you are cordially invited. We'll send you a link. If you're interested, you can join this training program without any registration fee. Multiple logos which evolved over a period of time. That's what is depicted over here. That is where April 2000 we started with, and that is here April 25. We completed 25 years of echo educations. This course started on 9th April. It's a long way we have gone. We are likely to have a hands-on session for registered delegate from October 30th to 2nd November 2025 in Delhi. And I'd like to welcome you all to this session of evaluation of exam on CAD, cardiopathy and diastology. As I said, I'm Dr. Rakesh Gupta from Jorap Institute of Echocardiography, Ultrasound and Vascular Doctor. It's going to be a unique work. I'll be calling name one by one according to your roll numbers, and then you have to answer the question which everyone of us will understand. If you're not able to answer the question, then I'll pass on this question to the next person. So my name is Rakesh Gupta, so I'm going to take this exam along with you. My mobile number is 9811013246. And can I tell you one thing? This number is very simple. If you have a telephone number, this was the first number which was introduced by Vodafone in India. That was 98110 in Delhi. Then you dial 1 and then you dial ECHO. It automatically goes to 3246. My email address, very simple. It is begin with my name, attach echo with it, and goes with a Gmail. Let's start with the question from our first. Mitral Doppler spectral flow in this patient where EA ratio is more than 2 with reduced ejection fraction of 42% in AP4C view, suggesting apical hypokinesis. It's suggestive of what? Roll number 1, Dr. Muzaffar Naik.
Good evening, sir.
Good evening.
Grade 3 diastolic dysfunction.
Grade 3 diastolic. Perfect. Dr. Muzaffar, excellent answer. This is grade 3 diastolic dysfunction. Roll number 2. The Doppler spectrum pattern across pulmonic veins suggests. This is Dr. Abhijit More. Abhijit?
Sir, normal LV filling pressure.
Why you say is normal?
Sir, SD ratio is more than 1.
Correct. So systolic versus diastolic, there's a tall S wave and a small D wave. It's a continuous phenomenon. Look, it's a very extensive thing. The pulmonic vein keep on pushing blood, whether it's systole or diastole. The same thing happened in other side, on right side. Where? Abhijit, can you answer me this question? On right side, where it happens?
Yes, sir. Sir, pardon.
The same phenomena happens on right side. All right. Dr. Navakant, can you answer me this question? The right side also shows the same phenomena. Dr. Navakant, are you there?
Yes, sir. Yes, sir.
On right side, where do you see this phenomena? Continuous flow, systole and diastole. Anybody can raise their hand.
IVC.
You don't have to speak, you have to raise your hands. Perfect. Dr. Veena Ban.
Pulmonary
Hepatic veins.
hypertension.
Hepatic vein to IVC. Perfect. Good, Veena. Great job done. So even hepatic vein shows the same thing. It shows continuous systolic and diastolic phenomena. All right. Let's move to Dr. Navakant now. In calculating diastolic function in atrial fibrillation, following parameters are used as per JS 2016 guidelines. Navakant, your answer.
Sir, I marked this wrong.
So
So there is no
whatever it is, what did you
A
mark?
wave in the. There is no A wave in the mitral.
Correct. There is no
I
A wave.
marked it as E by E prime lateral. I have marked it.
All right. So would you like to change now?
No,
No.
I've seen the answer there. It is E by
Okay, fine.
E prime
So
septal,
the
but
answer
I don't
is
know why.
we want to take E to E prime septal, EVP ratio, IVRT. Okay?
Okay.
That should be your answer. Then next question goes to Dr. Survase. I can see Dr. Smiling Survase now.
Yes, sir.
In case of heart failure with reduced ejection fraction, following set of parameters suggest EA ratio 1.4, E to E prime average 11.4, TR jet velocity 2.8, LA volume index 36. It suggests what? Be careful.
Yes, sir. Grade 2 with raised LV volume.
Grade 2 with raised LA volumes. Is everybody happy with this?
Yes.
Yes, sir.
Yes, sir.
Yes,
It's
sir.
reduced ejection fraction. It's not a preserved ejection fraction. It's a reduced ejection fraction. All of the answers are wrong. It's a grade 2 raised LA pressure, not volumes.
Sir,
Go to 2016 guidelines. Correct,
Sir,
wrong, or right? Is a grade 2 with raised LA pressures.
sir, we
LA volume index is also high.
is more than 34.
But when we talk of a reduced ejection fraction, we always talk of pressures, not of volumes. Okay?
The pressure, sir, TR velocity
Yes,
is
sir.
more than 2.8. So this.
I'll have to stop sharing this slide. Just give me a second. Can you see the slide now?
Yes, sir.
So we belong to this category. This is grade 2 diastolic dysfunction with the raised LA pressures. It's not volume, it's a LA pressure. It's a LA pressure. It's a LA pressure. I know you are going to create a mistake. If I would have written LA pressure, everybody have suggested LA pressures. So whenever we talk of ejection fractions with reduced, we look at a diastolic function by this particular methods. Okay?
Yes.
I'm sorry, I'll have to go back again because that link got disconnected. So I'll have to fill up that link again. Can you see my screen now?
Yes, sir.
Okay. I'll quickly go for it. No, it's already there. So this is what we leave. We're not going to give any marks for this. Question number 5. In case of valvular region, what is the most important parameter in diastolic function? In case of valvular region, MS, MR, what is the most important parameter? Dr. Shiva Kumar. Shiva, are you there? Dr. Chirag Gulbani. Dr. Chirag, are you there or not there? All right. Dr. Mahua Roy.
Sir, I have written E by BP ratio, but here the answer is IVRT, but both are important.
E2, what did you write?
I have written E by BP ratio.
Okay. Anyway, the answer is IVRT. That is the most consistent word. Anything less than 60 milliseconds is considered as elevated filling pressures. All right. Heart failure with preserved ejection fraction is seen one of the set of parameters. Dr. Deepak M.
Good evening, sir. I am sir Dr. Chirag, sir. I was here only, sir. I am not able to unmute the thing, sir.
Okay, now wait a minute, Chirag. I'll come back to you. Dr. Deepak, can you attempt this question?
Sir, I have written third option, sir. E bar E prime, but correct answer is fourth one.
Look, ratio has to be more than 10. TR velocity has to be more than 2.8. LA volume index has to be more than 34 cc.
It's a 34.
PA ratio between 1 to 2. That is the ratio.
Normal parameter.
So correct answer is C, D. Okay, Dr. Chirag, go ahead now. All possible treatment of diastolic heart failure except.
Sir, I have marked it as a beta blockers, but sir, I was having doubt with ACE inhibitors also, sir.
You know what is diastolic heart failure? Raised LA pressures.
So with preserved ejection, heart failure with preserved ejection fraction.
Anything which has got a preserved or reduced ejection fraction, the preload is high. And
Yes,
in this patient, like you treat a target, you use SCLT2 inhibitor in preserved ejection fractions.
Yes,
ACE inhibitor, ARBs, they reduces the preloads.
okay, sir.
Okay. This picture suggests what? Dr. Deepak M. You have answered, Dr. Deepak. Pratik Rajesh Shaw.
Sir, the E by A ratio is less than 0.8, so there is a diastolic dysfunction which suggests of elevated filling pressure, sir. Elevated LV-EDP.
E wave is less than A. E is taller than A.
E by A ratio happens to be, sir, less than 0.8 because A wave is almost equal to E wave here, sir.
Dr. Ramavatar, you will try. You are right, but why you are right, you are not correctly saying. Dr. Ramavatar, he is not there. Dr. Madhu Seni,
Yes,
Dr.
sir. Yes, sir. I'm here, sir. Good evening, sir.
Good evening, Madhu. Tell me what is the answer?
Sir, answer is B, elevated filling pressure, but I marked it wrong. I marked severely elevated filling
Look,
pressure.
this is L wave. Mid diastolic L wave. This is a characteristic of elevated filling pressures. It's a very early sign for elevated filling pressures. There was a time when we used to look at just L wave and say the LA pressures are built up. Okay?
Okay, sir.
Dr. Veena wanted to ask something.
Sir, why it is not severely elevated? Means how to differentiate between
Wow,
elevated and
that's a
severely?
good question. Why it's not severely elevated? Can't spend a lot of time on diastology right now, but this is one of the marker for mildly elevated filling pressures.
Sir, I also mark severely elevated.
No, it's a mildly elevated. It's not severely elevated.
Okay, sir.
When I was your age, I also did the same thing what you did today. It's a long story. I can't spend time on diastology right now. And you know, the diastology guidelines have been revised a week back only. Anyway, let's move to the next one. Normal IVRT, Dr. Prajakta Pote. Dr. Pote.
Sir, A 70 to 90 milliseconds, sir.
Okay, can you tell me any other method of calculating this IVRT?
Sir,
No, sir. I will move.
Anybody else would like to take this? Raise your hand.
Sir, we can keep the pulse wave Doppler in between the aortic and mitral valve, and then we can get the interventricular
No, we
relaxation.
don't keep pulse wave Doppler. We have to keep continuous wave Doppler to interrogate a timing interval between closing of aortic valve and the mitral opening of mitral. That's one. Anywhere else?
Sir, it is inversely proportional. It is less than 70. It is inversely. It prolongs with normal LVDP and it is shortens with raise LVDP.
Somebody's mic is on. Please stop.
Sir, it is. We have no Budweiser Magnum can. So, good evening, sir.
Dr. Lavkesh, your mic was on. Look, if you're doing a practice or you're busy at home, please exit at this present moment. And next time my IT person will shunt you out, and then at that time, don't feel bad about it. Dr. Lavkesh, your mic was on, so he had to shut your mic. If you're not interested, please exit. Okay? All right. Restrictive flow pattern has flow propagation velocity of Dr. Shushma Kirti Gaurav.
Sir, yes, the right answer here is less than 35.
Correct.
But I have marked it wrong.
Whatever it is, that's a different issue. Next, ejection fraction in LV systolic function is dependent on what? Dr. Kirana, Dr. Major Kirana. Are you there, Dr. Major Kirana? Dr. Raghavendra HH.
Sir, that depends on the all, sir, like a preload, afterload, and heart rate,
Correct.
sir.
So we cannot depend on ejection fraction to a large extent, you know. If I'm volume depleted, I've got a high ejection fraction. If I'm volume overloaded, maybe underloaded ejection fractions. Tachycardia will increase the ejection fraction. Bradycardia may reduce the ejection fraction. So it's depend on many factors. All right. So all of the above would be the correct answer. The correct method to calculate ejection fraction by 2D echo. Dr. Vikram Bhagchand Khurd. Dr. Vikram Bhagchand. All right. Dr. Lovedeep Saini.
Yes, sir. So it is modified biplane Simpson's method.
Correct. Perfect. Next question is, as per ASC guidelines, normal ejection fraction is Dr. Rijul Saini.
Yes, sir.
Tell me
Sir,
what.
it's more than 55. Hello?
Yeah, I'm hearing you.
Sir, it's more than 55% in female and 53 in male.
Well, gentlemen, is 54 and 52. Females are more masculine than males. All right. The method shown over here is what? Dr. Gaikwad Anshuman Jaisingh. Anshuman Gaikwad Jaisingh is not here. Dr. Shantanu Pramod Mal. Santanu Pramod Mal.
Yes, sir. With respect to this, yes. The figure questions, sir, right, sir?
Yeah, figure questions.
Yeah. Modified Simpson's method, sir.
Perfect. These are diskettes. कभी हम कैरम खेलते थे बचपन में. So one after another, the carom boards discs are kept. So that's why when we calculate ejection fraction, the machine calculates in this particular format. Which of these methods to calculate ejection fraction which correlates best with cardiac MRI? Tajinder Kaur.
Yes, sir. It's 3D echo method, sir.
3D echo method. So nowadays, number of time, if we have a 3D probe, we are taking ejection fraction by all 4-chamber, 3-chamber, and 2-chamber echoes windows.
Yes, sir.
In absence of ejection fraction, which M-mode method is good for assessment of LV function? Dr. Parihar, Lovekesh Singh Parihar. Dr. Lovekesh Singh. Dr. Ravi Shankar GS. Dr. Ravi Shankar.
Sir, M-mode.
No, it's a MAPSE, mitral annular plane systolic excursion. You put a cursor across that mitral valve and look how much excursion has happened.
Okay.
Sir, why not myocardial performance index, sir?
It could be myocardial performance index also, but myocardial performance index is used majority of time for prognostication purposes.
Sir, because in question it was written LV systolic function, sir.
Yeah, it is true. I'm not saying this. MAPSE is more important because, you know, like when we were happening this COVID time, this is one parameter MAPSE and TAPSE were using to a large extent in the absence of ejection fractions. So we put more emphasis on MAPSE rather than myocardial performance index because myocardial performance index is used most of the time for, I don't say not for systolic function, but most of the time for prognostication. Higher the myocardial performance index, poor is the prognosis.
Okay, sir.
Question number 17. Dr. Ravi Shankar GS.
Yes, sir.
What is the answer for 17? LAD territory 16 segment model.
Sir, I don't know.
Dr. Abhijit Gowder.
Sir, option A.
Abhishek.
Sir, option A, sir, apical septum, lateral apical inferior wall of anterior wall.
4-chamber view apical septum lateral, 2-chamber view apical inferior and whole of anterior wall, 3-chamber view mid and basal anterior septum. So, Dr. Ravi Shankar GS, you have to be little careful now.
Okay, sir. Okay, sir.
The coronary artery of supply of RCA, Dr. Chandrakant Patil.
Good evening, sir.
Good evening.
Answer B, mid and basal septum, mid and in basal inferior wall.
Where do you see mid and basal septum? Which view?
What, sir? Mid and basal septum, sir. Seen in a apical 4-chamber view, and mid and basal inferior wall seen in a apical 2-chamber view.
All right. The LCX territory, Dr. Chandrakant Patil has done. Ashish Rathore.
Sir, it's mid and basal posterior lateral wall.
Perfect. Where do you see this?
In apical 4-chamber view, sir.
And
apical 2-chamber view, sir.
बॉस पढ़ते नहीं हो आशीष जी.
Yes, sir.
तुक्के मार रहे हो?
नहीं सर, नहीं.
अरे तुक्के मार रहे हो भाई. 2 chamber व्यू posterior wall आएगी, lateral wall आएगी.
Left wall.
Hey, wait a minute.
Lateral wall.
Don't jump.
Lateral wall आएगी sir.
2 chamber
lateral and inferior.
एक मैडम ने बोली है 2 chamber व्यू lateral wall है. 2 chamber व्यू lateral wall
it's anterior. It's anterior and inferior wall, sir. Sorry. Sorry, sir.
तुक्के मार रहे हो भाई.
नहीं.
एक मैडम पीछे तुक्के मार रही है बैठ के. anterior wall आएगी. 2 chamber व्यू. सोचने से पहले बोलो. रिकॉर्ड हो रहा है ये?
Yes. Yes, sir.
YouTube पे जाएगा.
Yes, sir.
All right. Question number 20. Renu Dahan.
Yes,
2D,
sir.
2D stain LV systolic function is used to assess what?
Subclinical left ventricle systolic dysfunction.
Perfect. Good. Dr. Kamal Kishore. In today's circumstances, is best to use imaging for 2D. Fundamental, harmonic, M mode, 2D.
So harmonic, sir?
Why you say harmonic? Can you explain it?
So harmonic is the best way.
Speak little louder.
The harmonic this probe was the best.
What do you mean by harmonic?
So there is no need to go for lower frequency or higher frequency. It is managing the
No. Can you move on to Dr. Deepika Joshi? What do you mean by harmonics? Deepika ji, good evening.
Yes, sir. Good evening.
बताइए ना.
Sir, idea नहीं है harmonic image.
Okay. Harmonic imaging is when you send an impulse beat of 2 megahertz, it receives back from 2 to 4 megahertz. As we understand in adult population, we need a depth. For depth, we need a lower frequency. But for nearer imaging like apex, we need a higher frequency. So the machine sends back 2 megahertz to 4 megahertz. So that is known as harmonic imaging. Okay. So in today's, if somebody is trying to sell you a fundamental imaging, please do not buy it. All right. The stroke volume across left side and right side can be calculated by Dr. Deepika.
Sir, option number. So A, option number A. So actually, I marked it wrong, but the correct.
What do you mean by what exactly you're trying to say if you're saying option A? LVOT VTI, how do you get LVOT VTI? How do you get LVOT area? पढ़िए दीपिका जी.
Yes, sir.
So what we do, we get LVOT VTI in apical 3-chamber view or apical 5-chamber view, put a sample volume just before aortic valve, we'll get VTI. We measure LVOT dia in Plaque's window. So that will get you stroke volume, that we get a stroke volume across LVOT. In RVOT, go to patient short axis view at aorta, look at an RVOT VTI and RVOT area. The myocardial performance is used for assess systolic, diastolic, both systolic and diastolic, none of the above. Somebody has said this word, and I'm sure Dr. Renu Dahan or somebody said these words. Yes, it's a systolic function, but majority of time is used for prognostications. In the absence of ejection fraction, which Doppler method of is good for assessment of LV systolic function? Now I have removed your taps over here, maps over here. So now you can say left-sided myocardial performance index. So what is the normal end-diastolic and systolic volumes in male? Dr. Shankar Gowda. Are you there, Dr. Shankar?
Yes, sir.
What is the normal LV volumes?
Sir, it is 30 option A, sir, 34 to 74 in
Yeah, you have to remember this.
diastole
I'm
and
sure like
7 to
everybody
13.
does not remember them. Remember 34 to 74 and it reduces by 2/3. Sorry, it reduces by 1/3, not 2/3. It reduces by 1/3. At least minimum of. And what is the normal end-diastolic volumes? It's again A. This is a figure you can put in a chart in your room to just look at these volumes again and again. Why these volumes are important? Sometimes we are underrated volumes are there. When your LV cavity is small, you have a higher ejection fractions. Your cavity is large, you may have still good ejection fraction. So in that time, it comes handy. This picture suggests presence of CAD with LV thrombus. Can you suggest territory, Dr. Subhashish Das? Dr. Subhashish, are you there? Dr. Madhav Bansal.
Sir. Yes, sir. It is LAD and RCA.
Why do you say RCA?
So because this septum, mid-basal septum is also involved.
What is involvement of basal septum?
It is almost a kinetic, sir.
And
sir, apex is kinetic.
No, I'm not asking apex. I know you know the apex. About basal septum, why you say akinetic? Anything else apart from this basal septum?
So it is thinned also, thinned out.
Thinned out, akinetic, hyperechoic. Look, it's brightened up shadow.
Yes, sir.
That's why we say it is akinetic, hyperechoic.
Yes. Yes, sir.
Look, this is what very important thing is. This patient had an old inferior wall MI and developed a fresh insult in LAD territory.
Yes, sir.
Okay?
Yes, sir. Yes, sir. Thank you, sir.
Next one. Dr. Veena, it's all yours.
Yes, sir. Proximal LAD, sir.
Why do you say proximal LAD, Veena? Just
Because,
one line.
Basal anterior septum is also affected.
Perfect. Great. Good job done, Veena. God bless you. So it's proximal LAD. This picture suggests what? Dr. Chaitanya Bhujbal. Are you there, Dr. Chaitanya? All right. Dr. Samu? Dr. Samu, are you there?
Yeah. Good evening, sir.
Good evening. Tell me, what is the territory involved?
I've written here proximal LAD lesions, right?
Okay, fine. Why do you say proximal LAD lesion again?
I can't hear you too much. There is a problem of connection here, I think so.
Okay, why do you say it's a proximal LAD lesion? We say proximal LAD lesion again. Look at this basal anterior septum is hyperechoic. We have LAD involvement over here. We have LAD involvement over here. We have LAD involvement over here in two-chamber view also. And if this is kind of a patient which present in your practice with acute MI, majority of these people, they need interventions.
Acute interventions, actually.
Correct. Acute intervention.
Acute interventions, yeah. There was no good reason.
Correct. So can you try
Thank
this,
you,
Dr. Samu? One more for you. Which territory?
Left main, I think so.
No, this question number 30. Which view is this?
Apical 2, I think, chambers.
Correct. Two chamber view. So what do you see? This is what wall is this? What wall is this?
Anterior and inferior.
Correct. So any abnormality interior wall?
I don't find any abnormality. I find in the inferior basal.
Okay. And so what territory it is?
I think so. CS complex down.
It's a basal and mid and basal inferior wall suggesting RCA.
RCA. Yeah.
Okay.
Yeah.
All right. Now this suggests CAD and the number is Dr. Muhammad Ismat. Ismat, when you don't try?
Yeah. Good evening, sir.
Good evening.
Sir, I'm at LCX, sir, left circumflex artery.
Why do you say left circumflex?
Sir, it's a papillary muscle involved, sir. The level.
What is the territory for circumflex in four-chamber view?
The lateral and or the posterior wall, lateral segment on the left ventricle, sir.
Lateral wall on the left ventricle. Okay. In four-chamber view, which territory do you see?
Lateral wall, sir.
This is septum. This is lateral wall. Look, this is hypokinetic, man.
Lateral, sir. Lateral hypokinetic. Actually, I thought hypokinetic.
Mid and basal lateral wall are hypokinetic.
Yes, sir. Yes. Thank you, sir.
All right. Now the next question goes to Dr. Priya Brata Das. Dr. Das, yours. LAD, LCX, RCX, PCX, KLX. Which territory? Dr. Priya Brata Das. Dr. Das, are you there? All right, he is not there. Dr. Priya, she's a technician. Dr. Priya Ravindra Singh. Priya,
yes, sir.
Go ahead, Priya.
Yes, sir.
Which territory?
Sir, I didn't mark this question. Because sir, it's look like all segment contracting, only lateral, basal lateral, I have doubts, sir.
This is contracting something apical, sir. Apical septum.
Sir, so LAD is there, sir.
Possibly LAD.
Yes.
Even I'm very doubtful whether this is LAD or not.
Yes.
This appears to be apical lateral. That's apical septum. That's all. Let's see.
Sir, basal septum is also not moving properly.
Basal septum, this part is a normal phenomenon.
Okay, sir.
All right. Next is Ravi Kumar Nimala. Ravi, tell me what is there. This is a post-MI rupture. This is ventricular septal defect. This is LA, LV, aorta. This is interventricular septum. This is a ventricular septal rupture. And this is a deadly condition. You have to react very fast. Otherwise, the patient majority of time collapses because there is a virtually equalization of LV-RV pressures. In this picture suggests presence of CAD. If so, which territory? This goes for Dr. Shamina Sultana. Shamina?
Sir, all the walls are contracting normally.
Correct. This is a dicey question. Is this picture suggestive of coronary disease? No, it's normal. All right. Then next is Dr. Shahbaz Mohammad Kareem. Dr. Shahbaz Mohammad Kareem, give me the answer. He is not there. Satyam Likha. Dr. Satyam Likha. This is a classical example of mid-cavity turbulence. Look, turbulence is not aware. Turbulence is in mid-cavity. It's a variety of hypertrophy which give rise to not LVOT gradient. It give rise to a gradient in the mid-cavity.
Mid-ventricular hypertrophy.
Yeah, it's a variety of hypertrophy.
Yes, type of hypertrophy.
Correct. So next is Dr. Tejasvi Mathur. Dr. Tejasvi, when you take this question, are you there or not there? Dr. Mohammad Arman Jaid.
Yes, sir.
Answer.
I think, sir, this is third option, dilated cardiomyopathy.
Something more than this. Look, these are sieves, multiple sieves. Heavy tuberculations are seen. These heavy tuberculations are seen in a variety of dilated cardiomyopathy with non-compaction.
Spikes, sir.
Pardon? Can you see this tuberculation?
Spiky type of appearance.
Yeah.
Yes, sir. Yes.
This is a very characteristic of these people. If they're true by congenital, they don't live to the age of 25 to 30 years. A child we have recorded where the child was born with this non-compaction.
Sir, why the word non-compaction is used?
Compaction is the segments don't get compacted. We have three segments, endo, my, and pericardium. Endo and myocardium do not get completely compacted with each other. They do not touch with each other compacting. Compaction does not happen.
Okay.
Look, we can
Okay,
separate myocardium from endocardium. Yeah. So what used to happen? Number of names have been given to this. This is being spongy myocardium, non-compaction, heavily tuberculations. At one time, people used to say that it is multiple thrombi are present. The problem is when the blood flows into these sieves, they get thrombi formations. This can happen in dilated cardiomyopathy in adulthood, but true non-compaction, well, the person do not rise to 30 or 40 years of age. Dr. Sharmina, go ahead.
Sir, I think this is spontaneous echo contrast within
Yeah, this
LV.
is spontaneous echo contrast. Correct. Absolutely true. Great. And Dr. Veena Bal, you want to say something? Go ahead.
Why there is significant pericardial effusion also along with this?
Here is a pericardial effusion. Whenever we have a dilated cardiomyopathy, RA pressures, RV pressures, they are large and they in fact land up with pericardial effusions.
Okay.
Sir, I want to.
Go ahead.
Sir,
Go
sir,
ahead.
I want to ask that where is the trabeculation ridges? Sir, please mark, sir.
Why the tuberculations?
And ridges without, for non-compaction.
I'm sorry, I couldn't pick up your question. Can you say it again?
Sir, the answer is DCM with non-compaction.
Correct.
Where is the trabeculation and ridges in this LV?
The trabeculation enriches whenever this LV becomes dilated. Look, there are two kind of a thing. One is congenital, second is acquired. Congenital is there is non-compactions. In that is the people they live up to age of 30 years or 35 years. Then this is adult variety where the patient develop LV, dilated LV and give rise to this kind of pictures where this has become the spongier, heavily tuberculated segments. Why? I'm not really sure what exactly the answer for that is.
Okay, sir.
All right, question number 37. So we have Dr. Mohammad Arman Jaid is there?
Yes, sir.
Answer. What is the answer, Dr. Jaid? Remember, this is a very classical picture of ARVC, arrhythmogenic right ventricular dysplasia, where majority of that RV apex is heavily tuberculated. And you have a TRZ gradient of less than 30 millimeters of mercury. If you remember this picture, never forget this. This is classical of ARVC.
Okay, thank you, sir.
Dr. Qasim Ali. Qasim, are you there? This picture is, look very carefully. This is caudal SAM. This leaflet chords, they get into LVOT. It's not the leaflet. Leaflet is over here. The cord gets into LVOT and they produce a feature like hypertrophic obstructive cardiomyopathy. But this hypertrophic is not there. It's a cord which is obstructing. Long elongated cord gets into this. And it's very classical of this. Look, the valve or cords are moving 2 times with every systole and diastole. This is a picture of apical hypertrophy. Look, bays are comfortable, apex has become hypertrophic. And these people, they present with symmetrical T-wave inversion, V1 to V6.
Sir, amyloidosis picture is also similar.
Amyloidosis could be, but once we talk of amyloidosis, we have to have a 2-dimensional stain along with it. It could be amyloidosis. I can't say no to it.
Yes, sir.
It is looking like amyloidosis.
Looking like amyloidosis, sir.
It is looking like amyloidosis, or you can say that it could looking like a, but we wanted to show you a majority of picture is apical hypertrophy. In amyloidosis, another important feature will be not, valve leaflet would not be so mobile. They are thickened, restricted movement of valves are there. Next is, this picture is suggestive of bilateral non-compaction. Look at the non-compaction extending to right hand side also. Very poor LV systolic functions. This is our patient who had DCMP, a large thrombus virtually occupying 80% of the heart, LV cavity. We did a CRT device, we did everything for her, but we lost her. Except for a lung heart transplantation, we had no answers for her. And you know what was the story? This came from subsequent pregnancy once she had a peripartum cardiomyopathy. Second child, she born a second child despite having a peripartum cardiomyopathy. I never forget this lady. She was very courageous. She said, whatever it is, I have to bear a child. Next picture is suggestive of what? Dr. Kasim has joined. Let me ask Dr. Kasim. Good morning, Dr. Kasim. Anyway, this is a picture which is relative with, look, this is a mitral valve stenosis and which has led to TR-jet gradient. This is secondary involvement of a tricuspid valve. And this does not happen anymore now. This used to happen in 2010, 2011s. When we used to take care of only mitral valve. Now we are not taking care of mitral valve. If my RV annulus diameter is more than 40 millimeter in size or 4 centimeter in size, we always put a mitral tricuspid annuloplasty for these subset of populations. Very old picture.
Sir, why not restrictive cardiomyopathy? As
Why
both
not
the atria,
restrictive cardiomyopathy? Correct.
both the atria are dilated and ventricles are of
In
normal
restrictive cardiomyopathy, will not have this thickened leaflets in the mitral valve.
Okay. But amyloidosis has thickened leaflets, but it's not amyloidosis. Okay, sir.
Now this is restrictive cardiomyopathy. Look, is thin leaflets. Patient has got MTR. Look, LA is big, RA is big, and there's absolutely no correlations. Anybody who will raise their hand. Look, my job would be done perfectly today if anybody give me a correct answer for this. Can you raise your hand? Dr. Sharmina Sultana, go ahead.
HOCM, sir.
Why do you say it HOCM?
So there is fluid turbulence at LVOT.
Sir, there is SAM.
Sam is also.
I can't see Sam, man. I'm not a person taking care of 6 vision. Extra vision has not given to me. I
So
can't see Sam.
There is MR also.
MR.
Sir, I give ischemic cardiomyopathy.
Possible ischemic cardiomyopathy, sir.
Ischemic cardiomyopathy.
Turbulence in LVOT with MR.
Mid-ventricular causing LVOT obstruction.
Dr. Veena Bang?
There is asymmetric hypertrophy, MR, and there is a pressure gradient at LVOT.
I explained each and everything to you all people, like nobody gave me a correct answer. Asymmetrical hypertrophy, sucking of AML to the LVOT cavity, so we get turbulence. And mitral valve leaflet are left open, so we get MR. So look very carefully. As soon as you get the turbulence, the soon MR will come. This is a mid-systolic MR. This is a very classical sign of hypertrophic obstructive cardiomyopathy. Look carefully. The turbulence on MR, they comes together. Almost MR is following turbulence.
Yes,
It's a mid-systolic MR. So that's what need to say. Everybody say hypertrophic. Why hypertrophic? Okay. What are the following features of restrictive cardiomyopathy? Raise your hands now. Dr. Madhav Bansal, go ahead.
Yes, sir. Dilated LA, RA, and normal RV, LV, MR, TR, and elevated filling pressure.
How do you assess elevated filling pressure in restrictive cardiomyopathy?
Sir, by pulse wave Doppler across the mitral valve, we see the E wave will be more than 2 times of A wave.
Okay. Suppose restrictive cardiomyopathy has patient is in atrial fibrillation. So what parameter you will use?
Sir, in that case, IV, RT.
Okay.
And E prime, sir, E by E prime ratio.
E to E prime, what ratio? Septal, lateral, anterior, posterior, inferior.
Septal.
E to E prime septal. IVRT. What next? 3 parameters are there.
So VP.
Correct. So we look at E to E prime ratio, we look EVP ratio, we look IVRT to classify in atrial fibrillation restrictive cardiomyopathy. Good job done. The formula for calculating stroke volume in LV is, raise your hands. One first. Let's see who's the one. Correct. Veena Bang, go ahead.
Sir,
Veena Bang,
LVOT VTI into LVOT area.
how do you calculate LVOT VTI?
We have to first see the diameter. We take a diameter from the base of the at the outlet.
Which view?
Plaque, sir.
Correct. And LVOT VTI, what you take from where?
VTI, we have to take a trace of LVOT.
4 chamber view.
Pulse wave Doppler in either in the
4 chamber view. They can be 3 chamber view or 5 chamber.
Yes.
Put a pulse wave sample volume just before the aortic valve leaflets and trace that. You will get LVOT VTI. Good. And how do you calculate what is the question answer for RVOT VTI? Can I have somebody raise your hands? Good. Madhav Bansal, go ahead.
Sir, RVOT VTI into RVOT area.
Correct. How do you calculate RVOT area?
Sir, by the diameter at the pulmonary artery, at the proximal to pulmonary artery. And
which view?
Sir, this is aorta, short axis view at aorta level.
Okay, got it. So we have parasol short axis view at aorta, just at the level of hinge point of pulmonic valves. You calculate RVOT area. And then put a sample volume just in RVOT, proximal to pulmonic valve, you get RVOT VTI. Correct? What is QPQS ratio? Raise your hands now. Veena Bang again. Go ahead, Veena.
Flow across RVOT and LVOT.
Perfect. Where is used, Veena, this kind of things?
I'm not sure.
In shunts, like ASD. We want to see what like shunt volume is from ASD. So is the ratio is QPQS ratio is more than 2:1 to classify them as, look, this is a patient who has got large volume shunting through shunts.
Okay, sir.
All right, last 49, last but one. LV wall thickness is more than what to consider as hypertrophic cardiomyopathy? Raise your hands, Madhav Vansal.
15, more than 15 millimeters.
Okay. Then dynamic LVOT obstruction, Dr. Veera Bang.
More than 30.
30. All right, guys. Good question attempt. Let me see what's my result is. Whether I have passed or I have failed. Oh, I just crossed through. Okay, all right. We have done a good job. I think all of you will get your answers. And people who are absent today, let me name them. If they are present over here, they can tell me. Dr. Shiva Kumar was absent. Then Dr. Ramavtar Sharma was absent. Then Dr. Shushma Kirti Kumar Gaurav was absent.
Sir, I am present.
You did not answer my question, Shushma.
Yes, sir, I answered.
Okay, I'll take it for granted. Dr. Vijay Kirana, absent. Dr. Vikram Bhagchand Khurd, absent. Dr. Gaikwad Anshuman Jaising, absent. Dr. Subhashish Das, absent. Dr. Priya Barata Das, absent. Dr. Shahbaz Karim, absent. Dr. Satyam Likha, absent. Dr. Tejasvi Mathur, absent. All right, guys, have a great good night. Stay safe. See you next week with another episode of or another session of 51st Comprehensive Course on Echocardiography. And I'll again welcome you all on the 17th of August, 2025. We'll send you a link tomorrow. You can register yourself. Registration is mandatory but complimentary. So we'll try to send you a link tomorrow if you're interested. If you are in Delhi or you're close to Delhi, please join us on 17th August for a very interesting session. Let me just show you what this interesting session is. Let me stop the recording first and then move on to this particular session. Just give me a sec.